bringing together voices in child and youth healthcare. This is CAFC Presents.
CAFC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, and the McMaster Children's Hospital Foundation. We would also like to thank the following Keystone partners for their ongoing contributions that support all of CAFC's programs and activities. Hello, everyone, and welcome to today's episode of CAFC Presents. My name is Doug Maynard, and I'm the Associate Director at CAFC, the Canadian Association of Paediatric Health Centres. Today's webinar is titled Vulnerable Populations and Aboriginal Health, Time for a Curriculum, and it is part 3 of our 3-part series on social pediatrics that we've been presenting over the last about a little more than a month, I guess. As it is part 3 of this series, it's my pleasure to introduce someone who is starting to become familiar, I think, to the CAFC audience, who is Dr. Dennis Danneman. And I'd also, I almost always forget to remember this, but I'd like to thank the Paediatric Chairs of Canada, because it's with their prodding and support that we did this webinar series following a presentation that was done in conjunction with the Canadian Child and Youth Health Coalition back at the CAFC annual conference last year, and the Pediatric Chairs of Canada have asked us to continue bringing the topic of social pediatrics to the CAFC audience. So it's my pleasure to introduce the panel, who of course starts with Dr. Dennis Danneman, who's a professor of pediatrics and chair of the Department of Pediatrics at the University of Toronto, and is the pediatrician in chief at the Hospital for Sick Children. He'll be followed by Alain Tuleni, who is an adolescent medicine specialist at the Hospital for Sick Children and a lecturer in the Department of Pediatrics at the University of Toronto. We'll also be joined by Michael Moffat, Dr. Michael Moffat is a professor and was a professor and was the head of the Department of Pediatrics and Child Health at the University of Manitoba, and is currently the Executive Director of Research and Applied Learning for the Winnipeg Regional Health Authority. And finally, following Dr. Moffat, we'll have Dr. Jean Wittenberg, who is a child psychiatrist and head of the infant psychiatry program at the Hospital for Sick Children. And he's also the co-chair of the mental health promotion program, co-chair of infant mental health promotion at the Hospital for Sick Children in Toronto. So it's my pleasure to hand the virtual podium over to Dr. Dennis Danneman.
Thank you very much. This is the third movement in our 3-part series on social pediatrics. The first slide just shows an introduction and the fact that Doug and I have played a role in putting this together. The first one was basically an introduction to social pediatrics with a focus on education going both backwards and forwards in terms of affecting health and health affecting education, and was presented by Arjuman Siddiqui from the Dalalana School of Public Health in Toronto and Mariam Mehta from the University of Saskatoon. That goes back about 6 weeks now. The second one was the pediatrician as child advocate and child protector, and Lee Ford Jones introduced this. Jean Clinton from McMaster University talked about leveling the playing field, and particularly about early childhood development as being crucial to the outcome in children. And Sue Bennett from University of Ottawa and CHIO talked about child rights. And I think in ending this first webinar series, it's important to look at which are the children that are most vulnerable. And we're focused on 2 groups: inner city health, inner city youth, and Aboriginal children, but there could be very many other groups that come to mind as well, and will be part of future webinars. And then we've asked Dr. Jean Wittenberg, because of his experience in infant psychiatry and developing curricula in different parts of Canada and in fact elsewhere in the world, to say what are the things that we need to focus on in helping our trainees in pediatrics, in other specialties, in other non-MD specialties as well, learn about child health and social pediatrics. So without further ado, let me hand over to Alain Tulani and welcome her to this webinar. Alain?
Thank you, Dr. Danneman. Good morning and bonjour, everyone. Are my slides showing up okay?
Just try to make sure that we're speaking nice and loud so the audience can hear.
Okay. So over the next 15 minutes or so, I'll be talking about the vulnerabilities of inner city youth. And I hope that by the end of the webinar, participants are going to be able to identify high-risk behaviors among inner city youth, discuss factors associated with risk behaviors that may modify developmental trajectories, and also to review mechanisms to enhance resilience in this population. So all teens face challenges as they fulfill their developmental task of achieving autonomy and independence. And it's pretty much universally accepted that adolescence is a time of increased risk-taking behavior. Things like misusing alcohol or drugs, engaging in unprotected sex, or some types of criminal activity. And one reason for this may be that the teen brain is still developing well into adulthood and is probably less able to inhibit some of the impulsive behaviors compared with the adult brain. So according to the 2013 Ontario Student Drug Use and Health Survey, cannabis is the most commonly used illicit drug, with 23% of students in grades 7 to 12 reporting past year use, followed by non-medical use of prescription opioid pain relievers, such as codeine, at 12.4%. And between 2011 and 2012, Canada's youth courts completed just over 48,000 cases. And similar to previous years, these 10 types of cases accounted for over 70% of the youth court caseload. And the majority involved non-violent offenses such as theft, representing 14% of the total cases, and break and enter at about 8%. And the most common type of violent youth offense was common assault. And although high school dropout rates have decreased for both men and women from 19% for men and 15% for women in the early 90s, the dropout rates are still pretty high in 2012. And you can see here from this slide that they are about 10% for men and about 6% for women. So this graph shows teen birth, abortion, and pregnancy rates in Canada from 1990 to 2010. And you can see that overall, the combined teen birth and abortion rates went from about 45 per thousand in the early 90s to 28 per thousand in 2010. But over the last 8 years or so, the rates have pretty much stabilized. We also know that adolescence is a risk period for the emergence of serious mental health disorders. And we think that maybe the enormous amount of changes going on in adolescence likely contributes to the development of mental illness in those who are predisposed. In fact, studies have shown that about 75% of adult mental health problems have onset in childhood and adolescence. And this slide here shows Canadian data on the proportion of the population with a mental health disorder in the last 12 months by age and sex. And you can see that the highest prevalence of a mood, anxiety disorder, or substance dependence was among young adults between the ages of 15 and 24 years. And about 20% of women and 18% of young men were affected by a mental health disorder in the last 12 months. So youth living in urban areas of concentrated poverty need to overcome all of the challenges inherent in adolescence, but also at the same time try to navigate through the obstacles imposed by their often precarious environments. And it's well known that youth living in the inner city are at greater risk for many things like using drugs, dropping out of school, being involved with the court system, and teen pregnancy. So a group at the University of Washington documented the prevalence of some of these outcomes among 600 urban youth in Seattle, and they found that by the time these youth were 18, 26% reported having dropped out of school, 26% reported teen parenthood, 25% reported having been arrested, and 21% reported drug use other than alcohol, tobacco, or marijuana. Data from the U.S. Department of Education suggests that youth from low-income families have over 7 times the high school dropout rate compared to those families in the highest income quartile. And another study examining a nationally representative cohort of youth living in disadvantaged urban communities found that these youth were significantly more likely to engage in a range of health-compromising behaviors, things like theft, violence, selling drugs, compared to their non-urban peers. And when we look at data from Canada, this study of almost 800 marginalized and street-involved youth in British Columbia showed that street-involved youth were 3 times more likely to have been physically abused or sexually abused, and over half report a mental health or emotional health problem, and more than 1 in 3 have traded sex to survive. Interestingly, despite the substantial risks and the disproportionate rates of mental health issues in this population, we know that these youth are underutilizing mental health and substance abuse services. And although we don't really have much time to discuss this in great detail, I think it's worth mentioning, at least briefly, that street-involved youth also have substantial risks for physical health issues in addition to the mental health problems. So we know that they have disproportionate rates of HIV, hepatitis C, and other sexually transmitted infections. And we also know that they have shorter life expectancies, and we're talking here in the order of about 3 decades. So these risky behaviors and some of the vulnerabilities that I've discussed may actually alter life trajectories and lead to poor developmental outcomes into young adulthood. Although we know that the risk behaviors, we know about their risk behaviors, but we don't really know much about what young inner city children's expectations are for their future. And I think this is an important area of study because there has been previous research that has shown that positive expectations may have a positive impact on resilience and adjustment later in life. So to my knowledge, this report here, Longitudinal Follow-up of Poor Inner City Youth Between Ages 8 and 18, Intentions versus Reality, is the first to use prospectively collected data to link childhood perceptions in poor inner city youth with outcomes in later adolescence. And their objectives were to document at ages 8 and 10 children's perceptions of their future and also outcomes at ages 16 and 18. And they also looked at early childhood factors associated with what they call TAEs, or trajectory altering events. And these were defined as youth risk behaviors that had the potential to modify developmental trajectories. So when asked how likely it was that they would try marijuana in the future, 94% of children 8 to 10 years felt it was unlikely. 92% felt that they were likely to go to college. 93% felt that they were unlikely to get arrested, and 81% did not know that you could get pregnant after having sex for the first time. And you can see from this graph here the prevalence of individual trajectory altering events at ages 16 to 18, that 33% of youth had a positive drug screen, 19% had dropped out of high school, and 20% had become a teen parent. And interestingly, they found no relationship between childhood perceptions and intentions and later outcomes in adolescence. And more than half of the cohort, so about 56%, had at least one trajectory-altering event by the age of 16. So this table shows their final logistic regression analysis, and you can see that the odds of having a trajectory-altering event increased with greater exposure to violence. The odds ratio here was 1.14, and that was significant, and decreased with a better home environment, and the odds ratio here, 0.77. So this finding that early childhood developmental factors were associated with poor outcomes in late adolescence is supported by a lot of other research. So just as an example, these are 2 retrospective studies done primarily in white middle-class participants, but they did show statistically significant associations with adverse childhood experiences and adolescent drug use and teen pregnancy. So these studies, taken all together, suggest that progress in preventing youth risk behavior will likely necessitate reduction of adverse childhood experiences. And I think this theme has come up a few times in the previous Social Peds webinars. We have to start early. I just want to briefly mention 2 examples of early childhood environmental interventions. So this one here, the High Scope Perry Preschool Study and the Harlem Children's Zone Project that have found better outcomes in adolescence, in adults, and adulthood. So this preschool, Perry Preschool Study was a randomized control trial of 123 low-income youth in Michigan that provided half of the cohort with an enriched preschool at ages 3 and 4, as well as home visits. And they looked up until about age 40, and they found that adults at age 40 who had the preschool program, shown here in blue, had lower rates of arrests, committed fewer crimes, had higher earnings, were more likely to have graduated from high school and hold a job compared to those that did not participate in the preschool program. Also, a cost-benefit analysis showed that overall, The study documented a return to society of about $13 for every tax dollar invested in the early child care and education program. So similarly, the Harlem Children's Zone program is enriching the environments of children living in Harlem. And this intervention includes several things, including prenatal parenting classes, preschool programs, community-wide public health sessions, and financial advice. And they, too, have shown improvement in standardized test scores and increased graduation rates for their population. So we're going to switch gears a little bit now for the last few minutes and talk about how can we enhance resilience in inner-city youth. There's a lot of interest in looking at youth that have successfully negotiated risky environments to learn from them what protective factors may have promoted healthier development. And there's also growing acknowledgement that although the absence of risk may diminish morbidity and mortality, it cannot be our final goal. And a popular saying within the youth development field is that problem-free is not fully prepared. So this study here, Enhancing Their Likelihood for a Positive Future, The Perspectives of Inner-City Youth, was done by a group at CHOP, and it was published in Paediatrics in 2002. They wanted to learn directly from urban youth what factors they believed would make the most difference in influencing whether or not they would have a positive future. So this table summarizes the 9th graders' suggestions, and you can see that the highest rated items were solutions that promoted education or solutions that increased job opportunities. And they ranked helping youth get into college and the creation of more jobs very highly. Third rank was shared by more job training, keeping youth from dropping out of school, and having better books and computers for school. And the next tier of items focused mostly on opportunities for youth to spend their free time productively and have more positive interactions with adults. So teens believe that supportive solutions would do more to enhance their likelihood of reaching a positive future than attempts to reduce negative behaviors or disruptive surroundings. Things like commitment to school, connecting and bonding with responsible adults, having opportunities to partake in societies with jobs and leisure activities in the community. And many of the ideas generated and prioritized by youth in the study that I just described are also found among the 40 developmental assets described here by the Search Institute. And this is basically a framework of strengths and supports, which has become the most widely recognized and cited approach to positive youth development. So these researchers identified a set of 40 assets that foster positive youth development, and they placed them under 8 broad categories. So 4 internal assets, including commitment to learning, positive values, social competencies, and positive identity, and 4 external assets, social supports, empowerment, boundaries and expectations, and constructive use of time. And lastly, this study looked at the predictors of resilience among inner-city youth using very complicated structural equation modeling techniques, which I don't completely understand, but it was done longitudinally using data from about 900 youth. And they found, not surprisingly, that resilience was predicted by bonding to family and teachers, involvement in extracurricular activities, lower levels of parent discord, fewer adverse life events, and being less involved with delinquent peers. But the thing that I found most interesting about this study was that resilient youth became more resilient over time. So those youth that became, those resilient youth became closer to family members over time. They became more committed to school, and they became less involved with delinquent peers. So basically, they found a positive feedback loop in which resilience predicted further resilience. And I think that's a very important finding. So in conclusion, inner-city youth are at greater risk for drug use, school failure, adjudication, and teen parenthood compared with their non-urban counterparts. Poor home environment and exposure to violence in early childhood is associated with youth risk behavior in this population that may modify developmental trajectories into adulthood. And we do have evidence, strong evidence, that supports implementation of widespread public health initiatives aimed at improving the environment of poor inner-city youth in early childhood. And I think research and policies must also look beyond the reduction of risk and consider how to enhance the protective factors found within the individual teenager, their family, their school, and their community. Thank you.
All right, thank you very much. That was a great presentation. All right, so we're going to move on now, and this is my chance to remind the audience that there have not been any questions yet, but it's my chance to remind the audience that type your questions in as you think of them. Some great information there, and I'm sure there are some questions percolating out there, so be sure to type them in, and we'll get to them in the next break. So we're now going to move on to Dr. Michael Moffat in Winnipeg.
Is that it?
That's it. Yeah, we can hear you now. That sounds great.
Okay.
Go ahead.
Okay. Thank you, Doug. And so I'm going to talk a little bit about social pediatrics and First Nations, Inuit, and Métis children. And I'm going to present arguments as to why they can be considered more disadvantaged than many other groups in Canada. I always preface my remarks by saying that, first of all, I appreciate that probably most of us are standing on land that is either traditional land of Aboriginal people or is still disputed land claims. We have to have some respect for the history. I also say that I speak as a member of the dominant European culture, not as an Aboriginal person. So I present my own perspectives as a person who spent 40-odd years providing services to Aboriginal people in urban and remote areas. But I don't have the insight of being a member of the culture. So an outline of where I want to go, I will define who and where the Aboriginal children of Canada are, and very briefly provide some data, which is really the only data that I'll be providing, just to show the degree of disadvantage that they suffer. And then I'm going to talk a little bit about history, which is certainly steering away from my area of expertise, but I think we have to understand the legacy of colonialism. We'll talk about the social determinants and recently developed Aboriginal versions of social determinants. Briefly mention the issue of cultural safety and cultural proficiency within institutions in general, and particularly within healthcare. And then talk a little bit about moving forward. I don't have any answers, but I think we're in the midst of some very important societal conversations about Aboriginal people. Education is extremely important in this whole area, and there's a major discussion going on about education in Ottawa at the moment, which I will use as a case example. And then bring it back to healthcare, which is only one small part of the determinants of health, but it's the one that we mostly work in. So from the 2011 census, there were 1.3 million people who fit into the categories that are recognized as Aboriginal or Indigenous people of this country, First Nation, Inuit, and Métis. About half of them live off reserve and off their traditional territory, which means that they have actually undergone a process of many of them have undergone a process of urbanization. And that process is a much more recent process than those of us from the European community who moved off the farms in the last century or so. More than half of the Aboriginal people are children. I should point out that census data, notwithstanding the problems with the 2011 census specifically, are notoriously inaccurate for Aboriginal people because many Aboriginal groups don't participate. There are also about 300,000 non-status First Nation people who don't share any particular rights in this country, but they are First Nation people for all intents and purposes. And of course, there are an unknown number of people who share the genetic and heritage of our Aboriginal population. Other important things that we need to know, and this is really a critical issue, is that there is no single pan-Aboriginal culture or government. There are over 600 First Nations in Canada, and the Inuit have a territory and 3 large land areas that they occupy. The Métis are often provincially organized. Urban Aboriginal populations, which, as I mentioned, urbanization has really occurred in the very recent past, which I think is another stressor on Aboriginal people. Really have no voice, and non-status Indians often have no voice as well. So just to review our colonial history, the early contact period, most scholars agree, was actually relatively positive. First Nations were important allies to both the British and the French, although they picked different First Nation groups to align themselves with. Mutual survival in the colonies depended on collaboration in the early years. But the relationships began to change after the War of 1812, which was really the last war in Canada, of course, on our territory, and was a and after that, the use of war for settling disputes became less prominent in this part of the world, at least. But there were a lot more settlers, and there was a move to place Aboriginal people on reserved territories. Treaties were developed, and treaties were something that were well known to Aboriginal people. They had made treaties with other Aboriginal groups for years, but they had a different view of what a treaty was than the British who came here. They didn't see a treaty as a surrender of land. They saw it as an agreement for protection. Once we started moving colonists, farmers in, the Aboriginal people became somewhat inconvenient. And we had to either move them so that they wouldn't interfere with colonization, or we had to make efforts to assimilate them. We had clearly an idea that indigenous cultures around the world in general, but certainly here in North America, were an inferior level of cultural development. So there was a gap in our way of thinking about Aboriginal people. The first legislative event around Aboriginal people was in 1776, the Royal Proclamation. And it's quite a remarkable document because, and it's been a foundational document that the courts have resorted to in resolving Aboriginal disputes. But under King George III, this is the statement that is made in the Royal Proclamation, and it's really about preserving our relationship and establishing certain rights to both land and access to a living that was at that time seen as being important. Subsequently, however, a lot of our legislative events and policy decisions have resulted in a much more paternalistic approach to Aboriginal people. To some degree, sometimes stimulated by the idea that they needed protection, but also by the need to control Aboriginal people. So the Indian Act is well known from 1876, and it certainly established the role of the federal government in managing the affairs of Aboriginal people and to some degree control of their land and other access. Probably the most damaging historical event was our move towards residential schools, which wasn't the result of a single legislation, but it was an attitude that some people at the time felt that the only way to solve the Indian problem was to assimilate them, and the best way to assimilate them was to educate their children. You've probably been asleep if you haven't heard some of the stories that have come out of the Truth and Reconciliation Commission. This went on for over a century to varying degrees in varying parts of the country, and actually the last residential school was closed in the early 1990s. The legacy of this left a loss of family skills, mental health, and addictions. There's an intergenerational transfer of some of this legacy. 1976 possibly marks the beginning of a new phase with the Royal Commission on Aboriginal People. Was meant to be a blueprint for a new relationship. One thing that I would recommend that everybody in this country read is the summary of the Royal Commission that's available on the website of the federal government. It's an excellent document, and it really sets out where Aboriginal people were coming from and their feeling that they were ready to build a new relationship. Turning now to the determinants of health, Aboriginal children are a disadvantaged group, and they have all of the usual determinants of health or risk factors for poor outcomes, as listed here. But most people feel that they have some specific issues that are determinants of health. And people like Dennis Raphael rank Aboriginal status or identification as an Aboriginal person as a determinant of health itself. But you break that down a little bit, and it's about cultural continuity, self-determination, connection to the land, and the legacy of racism and marginalization that some of our colonial policies have resulted in. This includes policies such as residential schools and something called the 60s Scoop, which was prominent in Western Canada primarily, where we took a lot of children out of their homes and put them in good white foster homes, and it had very poor results. Looking at the determinants of health another way, Loppy, Redding, and Ween in 2009 wrote a paper that's available on the web, and broke the determinants down into proximal determinants, intermediate determinants, and distal determinants. The proximal determinants are things we generally know about: poverty, education, housing, health habits, nutrition, and food access. Intermediate determinants are about healthcare systems, often not very advanced in places where Aboriginal people live. Educational systems, also an issue. Community infrastructure, resource capacity, environment, and connection to the land, and cultural continuity. I'll mention self-determination in a minute. But so the distal determinants are the big historical and societal issues like colonialism, racism, social exclusion, and on the positive side, the whole issue of self-determination, which we forget frequently. Often quoted is a paper by Chandler and Lalonde from 1998. There aren't a lot of other positive papers around the determinants of health in Aboriginal people, but they looked at BC Aboriginal people and communities, and they found lower suicide rates in communities with higher levels of control over their services, social services, education, healthcare, etc., and their economic development. I think most people who think about this issue believe that we need to support this principle, not only at a societal level, but in all our healthcare decisions as well. We need to be very careful about making sure that Aboriginal people, both at the individual patient level and family level, and also at the community level, are partners in and are able to help determine the direction that they want to go. What's been going on this last week is an illustration that we haven't really generally gotten beyond the issue of paternalism towards Aboriginal people. The resignation of the National Chief last Friday of the Assembly of First Nations was a shock to some people. The education plan, which had to be withdrawn over the weekend, there was almost $2 billion on the table for education in Aboriginal communities. This is despite chronic underfunding of education in Aboriginal communities. Many many chiefs and the National Chief and the government being committed to the idea of improving education. So why did this fail? Well, there's likely a lot of factors. One is funding. There's a considerable debate about whether $2 billion is anywhere near the amount of money that's required. Another is about the authority of the AFM. I mentioned that there is no pan-Aboriginal community or government, and First Nations particularly consider themselves as individual First Nations with a direct relationship with the federal government. They don't recognize the authority of the AFM to make decisions, and they didn't feel that they had enough consultation. But the third thing, I think, is going to be the perception that Ottawa is once again telling Aboriginal people how to run their lives, the whole issue of self-determination. So we persist in, to some degree, in using our historical colonial legacy to do what's best for Aboriginal people because we know what's best for them, not without necessarily their full participation. Cultural safety just is an important, is now thought to be an important issue for Aboriginal people. I'm not sure that perhaps not everybody realizes that many Aboriginal people do not feel comfortable coming into our healthcare organizations. They do often suffer from culturally unsafe practices, which is defined by Cooney as any actions that diminish, demean, or disempower cultural identity and the well-being of individuals. And some of the historical things that I've talked about are reasons why they do not feel comfortable in our institutions, despite the fact that they have health issues that require access to healthcare. So moving forward, we need to obviously apply all the developing tools, toolkits and methods that are being developed for any type of Aboriginal or of disadvantaged group. But I think in addition to this, we need to do some of the following. We need to really continue the societal conversations that have started. We have to talk about history and culture. It's happening. One hopes that it's happening quickly enough and deeply enough. But starting with the apology for the residential schools in 2007, then the subsequent development of the Truth and Reconciliation Commission, which is now preparing to wrap up and has produced a huge amount of documentation. It's been more about truth, though, than reconciliation so far, and reconciliation still, I think, has a long road to go. But I think if you look around you, literature and art and media are full of often hopeful documents. The Canada Reads Award went to a Métis author this year. There's lots of Aboriginal literature, poetry, and all kinds of positive things. The other thing is that the business community is getting involved, and they are motivated by. Okay, that's my timer. They're motivated by the need for labor. And they see that the Aboriginal population, the youth, is expanding. I think the other hopeful thing is that academia, many universities have very stronger and stronger departments of Native Studies and other and more academic Aboriginal people who are starting to speak out and carry the conversation forward. Education, we need in our schools to tell the stories to all children about the residential schools and the history of colonialism. We need conversations and attempted legislation to improve Aboriginal education. I believe that process will continue despite the apparent failure this weekend. We also need programs to support Aboriginal post-secondary students. In healthcare, we need to develop programs to foster cultural proficiency, not just for Aboriginal people, but I think Aboriginal-oriented programs like the BC Cultural Safety Program and one that Catherine Cook and others have developed at the WRHA in Winnipeg help caregivers to examine their attitudes and their behaviors. And they have to understand the lessons of history. The process of educating more Aboriginal professionals is accelerating, but they are still grossly underrepresented in our health professions, and our institutions would be much better served, would much better serve Aboriginal people if they had more Aboriginal faces on the staff. And finally, briefly mention some of the benefits of outreach. There are a number of university centers that have done outreach for many years, including Manitoba. And all these first five benefits of outreach to remote and rural communities have actually been shown to be true in the literature. I think that these other ones are theoretical values of outreach that are worth pursuing. We need some models of urban outreach as well. Urban Aboriginal children are as disadvantaged as any group of urban children. So there's some overlap with what Aline was talking about earlier. So in conclusion, Aboriginal children are a growing population. They're very widely distributed geographically. They're very highly disadvantaged, and the legacy of colonialism and racism serve to reinforce and create them as a permanent underclass. Self-determination is key. We're really just at the start of our national conversation and reconciliation. And in healthcare, we can embrace cultural safety, train and hire more Aboriginal professionals, and foster outreach to bring services to communities. Thank you.
Moffat, that was you did promise at the beginning that mentioned that you weren't going to provide a recipe for solutions, but I think you did provide some great information that's going to generate lots of conversation for sure. We did have a question. Well, before we hand over to Dr. Wittenberg, we did have a question come in from Barb in Ontario, who's asking, can she have an example of culturally unsafe practice and how it might be altered to be culturally safe? You mentioned cultural safety at one point, including the program in BC on cultural safety. So I think he's asking in reference to that.
Yeah. Okay, and it's a good question. Let me suggest that that we do in healthcare, as in other social organizations and institutions, we do what the same thing as teachers and police and other people have a tendency to do, and we tend to do something that's a little bit like racial profiling. We have either based on past experiences or just based on the long history, we often consider that Aboriginal people are going to fall into particular categories of behavior that we don't expect, that we don't admire. And I've seen it happen many, many times that people will let the expectation that an Aboriginal person is going to behave in a certain way, interfere with their judgment about what is really happening. Of course, the most egregious examples tend to be examples of what happened in the Health Sciences Center emergency in Winnipeg with Mr. Sinclair a few years ago, where Aboriginal people are considered to be automatically part of a homeless and substance abusing group of people. And our first thought when something is wrong with one of those people goes to it's because of one of those things, as opposed to making sure that we gather all the information we need to make sure we know what is really going on with that person, because just because they have a history of substance abuse or homelessness doesn't mean that that's the reason why they're there that day. I don't know if that is helpful, but that's I would use that as one example.
Thank you for that great answer. We did have a presentation a while ago on CAPC Presents a few months ago from Karima Karmali at Sick Kids on cultural competence. I don't think they use that term cultural safety, but for Barb and anyone else who's interested in more information about sort of cultural competence or specifically in the healthcare setting, there is a presentation on the CAPC Knowledge Exchange Network that you may be interested in checking out. So, and again, an opportunity to remind the audience to type in those questions so we can start the discussion as soon as we finish our next presentation with Dr. Jean Wittenberg. So, Dr. Wittenberg, if you're ready, we'll hand the podium over to you.
Okay. So, first of all, I would like to thank CAPC for inviting me to join in this webinar, and also the two previous presenters. There are aspects of your work that I share and share interest in. I've been working with First Nations for some time now in Northern Ontario, and also have a strong interest in teen pregnancy, and I'm working with babies of teen mums. It'd be interesting to get into discussion about those things as we go along. What I'm going to present this morning is one approach to a curriculum. It's hard to be able to figure out what kind of a curriculum is needed for a very disparate group, but I'm going to give you an example of a curriculum that we developed for local healthcare workers to deliver to parents of young children. And in this case, it'll be children under the age of about a year to a year and a half. First, a bit of a review of information that all of you may have already. First of all, that the first couple of years are different, and very significantly different in a lot of ways. They set up our systems, and the experiences that we have influence those systems in ways that last all our lives. In a way, we could say that experience gets written onto us physiologically. So there are neuronal changes, the whole aspect of dendritic pruning, brain size, those kinds of things are very much influenced by the kinds of experiences we have in the first couple of years of life. Our autonomic systems are set to respond differently depending upon the degrees of stress that we experience in the first couple of years. Similarly with our hormonal system, especially the cortisol system. And if you are set in infancy to respond to everything as a trauma, as a stress, you continue to overreact in that way for the rest of your life. It's very difficult to get that turned around. Finally, even our genes and activation or deactivation of genes is set in those first couple of years, and once again is difficult or impossible to turn around. There is evidence that this impacts our health in many different ways, even from the intrauterine period of time, so that intrauterine stress does predispose to lifelong changes, including psychiatric disorders, particularly externalizing disorders in kids, and a lot of other kinds of adverse, or if the experiences are stress are with less stress, then more positive outcomes. We're of course concerned about more stress and adverse outcomes. Early childhood and neglect and abuse increase the risk for cardiovascular disease 7 times. I was astounded to find that out. And for mental health problems 10 times. It's clear that our stress systems get set up in infancy, and how we deal with stress then is set and influences our health in all kinds of ways for the rest of our lives. Early childhood neglect and abuse are directly associated with a smaller brain size in a dose-related manner, so that if you get more neglect and abuse earlier and it lasts longer, your brain is that much smaller. Socioeconomic gradients in health can be detected by age 3, so we know that there are real advantages to health to being born into a family that has advantages, that is able to deal with stress more effectively. And if you have more stress, your health goes down in all sorts of ways. And similarly, physical abuse is associated with more internalizing and externalizing behaviors if they occur before 5 rather than after 5. Some people have talked about violence to children being akin to smoking in adults. The degree of associations with health are striking. One way of thinking about this is to think about stress, which is a way that I've been thinking about it more and more as I've worked longer with infants. And we do have normative stress, and we all have some stress, and in fact, some of that stress challenges us to become resilient, to find solutions to problems. If stress is toxic stress, and you may have heard that term too, it is ongoing stress that one never gets on top of. And that's what causes the kinds of changes in the physiological systems that I was referring to before. And there's very good evidence tying toxic stress to those kinds of outcomes. Finally, there's emotionally traumatic stress. And often with toxic stress, there are repeated occurrences of emotionally traumatic stress, although that can also occur in the context of having a more normal stress-regulated life, and then becomes, on occasions, at least associated with post-traumatic stress disorder. Once you've got that, of course, you're set up for all other kinds of health concerns. One way then of thinking about stress and stress regulation is to think about the attachment system. And once again, I imagine most of you, if not all of you, know about attachment theory as developed by John Bowlby and a lot of people since that time. One way of thinking about attachment, the way Bowlby thought about it, was he talks about it as a way of negotiating feelings of security and insecurity in infants with caregivers, a system that then gets built in to the infants and determines a lot of how they deal with other people subsequently. In addition to that, however, it's also a way of thinking about or teaching infants through experience how to manage stress. So insecurity is a basic kind of stress for infants. And if we're able to help them manage it most effectively, they develop good stress management systems. And when that occurs, you get outcomes like better social relationships, very clearly better school readiness in kids who are secure. They get better mental and physical health. They develop better parenting abilities themselves. And so anything we can do to improve attachment security in the early years is likely to be associated with these kinds of very positive outcomes that sometimes get transmitted even into the next generation. What I'm going to talk to you about now is an intervention that we developed here in the infant psychiatry program at Sick Kids that now gets called Baby Love, Supporting Infant Security. And it's an attachment-focused intervention, preventive intervention, that we developed to train healthcare service providers in local communities to deliver to groups of parents, and have subsequently adapted it so that it can be delivered not only to groups but also to individual parents and infants, once again up to the age of about 15 months, 18 months if you really push us. The idea is to focus on fostering adaptive attachment relationships between the caregivers and young babies. We do have an evidence base for it now, and actually, interestingly, this evidence base comes out of working with the Aboriginal population in Northern Ontario. We know that parents who participate in the program are more sensitive to infant cues, particularly cues of insecurity, and they develop more reflective functioning, which has to do with being able to think about the baby's mind. And being able to, in that way, titrate a baby's experience and perhaps improve the baby's experiences of stress. It was designed initially in a 12-session version. We now have a more brief version, 6 or 7 sessions, and I'm going to go through those 6 or 7 sessions. As I said, it has both individual and group formats. And we're also now running a community education initiative with the idea that there can be influence for the infant by influencing many different levels within a community. The principles of Baby Love were that it be easily exportable and initially to be delivered by people like nurses, but since that time we've gone on and are training people in the villages in Northern Ontario who have much less training in education, and we're finding that they're able to deliver it as well. Important that it be culturally adaptable, and I think this very much builds on what Dr. Moffat was saying earlier, and it's low tech. So what I'm going to show you are a series of posters that are really the basis of our community education program. As you can see, each one of these posters has the same basic format, and each one corresponds to one of the 6 or 7 sessions. So the first one really has to do with waking people up to the idea that babies have minds. And perhaps surprisingly, people are surprised by this statement. But the idea is that we get this perception, this impression, this attitude across to the parents who are taking care of their babies. First of all, that the baby has a mind, and that they can learn to read the baby's mind. They can learn baby talk, essentially, by observing the infant. And by thinking about what the baby is thinking and feeling. They come to understand that if they pay attention to that, they can help the child feel more secure. And finally, we teach some of the outcomes that are associated with greater security in the infants. In the second session, we're focusing on the emotional and cognitive development in infants. I won't go into the details of the sessions except to say that we ask parents to tell us what they think babies feel and what they think babies think, and then work through that and help them understand, based on the evidence that is available, what babies really are able to think and feel, and try to correct misattributions. One of the most important things that we get across that are surprises both to the healthcare service providers as well as to the parents is that you can't spoil a baby by picking him up or picking her up when she cries. In fact, quite the opposite is true. The more often you are attentive to a baby who cries, the more likely the baby is to cry less in the future, and clearly the baby is going to be less stressed and more securely attached. In this session, we also teach attachment theory and the various categories of attachment, which I won't go into detail about today. The third session has to do with the transmission of parental stress to babies, and how, in fact, when parents of young babies are stressed, it's a hard year. I think parents repeatedly tell me they've never been as tired as in the first year of their baby's life. That fatigue by itself is a stress which is of concern in terms of parents being able to regulate their own feelings, but also the degree of concern they have about their child's health and development is an added pressure. And we begin to talk in this session about how that gets transmitted to babies, how parent feelings are transmitted to babies. And we begin to teach them ways of managing their own stress. As part of the program, we teach them mindfulness meditation, and we take them through each one of these sessions, beginning in the first session through a meditation exercise. In this case, what we do is we have them hold their babies while they're meditating and focus on their own breathing as well as the baby's breathing and movements. And what we find is that both parents and infants react very positively to this. When we run these groups in Ontario or the Year Centres here in Toronto and in the area, people tell us repeatedly that we run the quietest mother-infant groups they ever encounter because the babies are all settled. And repeatedly also parents have told us who have gone through the program that when they can't do anything else to settle their baby, they do a meditation with the baby, and the baby settles very quickly, which I think occurs because the parent has settled in the meditation. Also in this session, we teach them a problem-solving approach, which is just a way of staying organized when they're stressed and being more able to be creative problem solvers. The fourth session is about anxiety and depression in parents and how these affect children. And once again, we're trying to sensitize parents to the impact of their own distress on the babies. Both anxiety and depression are associated with a greater likelihood of having an insecure baby subsequently. Big problem has to do with anger and domestic violence and babies' exposure to that. Once again, this becomes a very important learning point, both for healthcare providers and especially for parents who tell us that as a result of learning these kinds of things, they've really changed the way conflict is dealt with in the home. And we help them in this find ways of dealing with their own personal anger and the baby's exposure to other kinds of conflict in the home. Very important issue has to do with the use of intoxicants and how, in fact, the use of intoxicants very clearly is associated with insecure attachment and disorganized attachment. This session and the session about violence and anger evoke a lot of very sensitive kinds of conversations in the sessions, whether they're individual sessions or group sessions that need to be dealt with. But they do also lead to significant changes in behavior. People very often make changes for their babies that they've been unable or unwilling to make for themselves. The final session then has to do with helping parents figure out ways of choosing alternate caregivers and basing this on is the space a good place for the baby, and subsequently to that, are the caregivers in the space good for the baby and supportive of attachment in the baby. So finally, just in conclusion, what healthcare providers I think need to know and what we need to base curricula on are they need to understand the associations between early experience and subsequent health. They need to be able to recognize risk factors associated with undesirable outcomes for infants. They need to become able to recognize stressed infants and stressed caregiver-infant relationships. They need to know when to intervene and when to make referrals. And I think finally, and perhaps the most important, they need to know how to use or access preventive interventions to support those relationships and infant mental health. And I think I'll stop there.
Thank you very much for that great presentation. Dr. Dan?
Could I make a few comments?
Yeah, absolutely. Yeah.
Am I on?
Yeah, you are on.
So thank you very much to the three presenters. I thought it was an exceptional series of presentations and highlighted some of the sort of deep-seated issues that we have to deal with. Maybe I could ask a couple of questions as a jump-off point. And if one looks at the social determinants of health and the outcomes of health in our Aboriginal children, they seem to be among the most difficult to deal with or to make change to in Canada. There have been a whole variety of different attempts to do so. Would Mike like to hypothesize on the next steps that ought to be taken?
And I'll just remind Dr. Moffat and Dr. Tulane to unmute their microphones.
Yeah, I keep missing where the button is. I found it. Dennis, I don't know what the next steps are, but listening to Jean, I think in terms of children, one of the best things that we could actually promote would be programs that actually help parents to parent better, and those have to be really culturally appropriate. They really have to be supported by us both intellectually and financially from the larger culture, but they have to be run and delivered by Aboriginal people or Aboriginal communities. One of the things, and John may comment on this, is that many people now feel that the legacy of colonialism has led to almost intergenerational post-traumatic stress disorder. But taking children from their families and putting them in residential schools and not allowing them to have any significant contact with their families, even though much of it occurred 3 or more generations ago, was an unbelievably traumatic and inhumane thing to do. And those children grew up without good parenting skills and without good family skills, and then their children and subsequent generations have had difficulty parenting in appropriate ways, and have also had difficulties with mental health and substance abuse and so on. So programs like this, we already know that the Aboriginal Head Start programs have actually been effective. Problem is that they're not universally available. They're not even widely available. Not everybody can get into them. I think there definitely needs to be more in that area. I think the whole issue of Aboriginal education also needs to be discussed. Why are we spending thousands of dollars less per capita on Aboriginal education on reserves than we do for other children in this country? We need to allow ourselves to come to grips with that.
So, am I on?
Yes, you are. Yeah.
I think the point that Mike makes is a very, very, very important one. John made it very strongly as well, that child health doesn't occur in a vacuum. It certainly occurs in the context of the family, and when you start with the family, you're really starting with the mother. And so maternal and child health need to come together to improve child and infant, and then even older children and teen health as well.
Can I make a comment?
Yeah, go ahead,
Am
John.
I on?
Yeah, go ahead, Dr. Wittenberg.
I agree entirely with what both of you are saying. The approach in terms of developing better health parameters in the Aboriginal communities, I think, has to do with developing capacity within the communities in a lot of ways. And really, that's what we try to do with Baby Love. Is we go up there, we train them how to do these interventions for the mothers and babies, so that their own people are doing it. Aboriginal women are running these groups and delivering the individual intervention and adapting it so it works not only within the broader culture, but within the local communities and with the local families. That's what we teach them to do. In addition to that, I think, though, that you have to think about the broader context of the neighborhoods and the communities that these families live in, and they need to develop ways of making the communities run better. If you think about the Chandler and Lalonde outcome study, in which there are lower suicidal rates and essentially in communities that run better. Communities that run better probably cause less stress and support family functioning better as well. And so a whole lot of better outcomes, including lower suicide rates, are very likely to follow from that. We can help families function better, but if they're constantly being very highly stressed by everything that's going on around them, they're going to have a lot of trouble maintaining that. In fact, that same kind of thing becomes true when you think about teen pregnancy. If you look at teens, and maybe especially the homeless inner city teens that we were talking about earlier, one of the big issues is stigma. And stigma for people like that and for the Aboriginal populations in most of our cities and even on the reserves is something that causes a great deal of stress. And it's to be found in the offices of our own healthcare professionals, our own healthcare service providers. When you treat people as stigmatized in that way, you increase the degree of stress on them. You increase the degree of stress, that gets transferred onto their babies and so on. It's very clear that being low status or a stigmatized person in a culture is associated with adverse health outcomes. So we do need to do those things. We do need to build capacity, and we do need to look at ways in which we interfere and actually compromise people's health through these ways.
Can I ask Elena to address a question?
Yes.
We talk about street youth, and this is obviously a spectrum, but the kids, the teenagers who literally sleep on the street or in shelters and have left home and are involved in a variety of different activities that you talked about. When you look at them 20 years later, what proportion of them have sort of re-entered what we could call mainstream society or a variant of mainstream?
That's an excellent question, Dr. Danneman. My impression is that the proportion would be low. I don't have the actual numbers. I don't know if Dr. Wittenberg or Mofat have any ideas, but I don't have the actual numbers. My impression is that it would be low. Given that their trajectories are affected for much further on beyond young adulthood. We know that their lifespan is affected. 65% of them are using substances in shelters. So I can't expect that they would enter mainstream society at a high proportion.
Because one always reads about these situations where somebody has been very underprivileged, disadvantaged, vulnerable, and makes it in the big wide world somehow, and those are sort of Malcolm Gladwell's Davids versus Goliaths, if you will.
Mm-hmm.
But I think one sees that this is a group that remains troubled for a long time.
For a long time, yes. And I think if you were to look at those that do well long term, you would find that they had, internal assets that were promoting positive protective factors. Things like, these people are potentially have higher self-esteem, have more positive relationships with adults. They have, positive identity, a sense of purpose. and those sorts of things. So I think that there is opportunity to improve the trajectory by enhancing resilience, and there are ways to do that, and focusing on both the internal assets and as well the external assets.
So is stay in school a good mantra to have?
Absolutely. Commitment to school has been shown again and again to have predict resilience and predict better outcomes into adulthood. Yeah.
I think one of the things that also predicts all of these things is a child having one good relationship in the midst of a lot of stress. And kids who have that then become more resilient as a result of that. They've learned a model for interaction and for relating that allows them to access other resources to develop relationships in positive ways. There is one finding which is kind of interesting to me because of how counterintuitive it was, which is when you look at teenage girls who become pregnant, the outcomes for many of those girls is better than for their peers from an equivalent SES who don't have babies. And what I've encountered repeatedly is girls who have a baby suddenly finding a purpose in life or a meaning in life, just as you were referring to, Alain, and turning their lives around as a result. So some things are unpredictable.
But that's not a message that we would like to send out today.
No.
Well, I think the message associated with that is that we want to be careful that we don't stigmatize those girls and make it even harder for them, because they are actually, some of them, a significant proportion of them, are pulling up their boots and doing better. And if we make it harder for them, they're more likely to fail. But no, I don't advocate having a baby as a good idea for most teen girls.
And I'd like to add that the stigma is sensed by the youth in that encounter with their healthcare provider. And these are patients that are not seeking healthcare to begin with. Their rates of healthcare utilization is much lower than their non-urban counterparts. So, getting rid of that stigma, improving relationships may help foster better continuity of care and health outcomes for these disadvantaged populations.
I think that's an important point. If I can say, is it that we tend to be very judgmental in our approach to groups like Aboriginal children or others. And that's not helpful. It's counterproductive. And it's the same thing when we're trying to build capacity, such as education capacity. If we tell them they must do it this way, that's not going to fly. We've been doing that for hundreds of years now, and it hasn't worked well. We have to work out with them what will work.
Lane, I think you had a comment there?
Yeah, just a very quick one. And Dennis, I'm sort of, comment for everyone, of course, in sharing, maybe planting a seed for future PCC discussions. When we talk about what we can do, Mike, you alluded to developing programs to foster cultural proficiency and help providers to examine our attitudes and behaviors. I think that, you, and I know everyone on the line, supports that and have said so in different ways today. I think that that's something as just one community represented on the phone today, but just one, as an academic community, as a pediatric academic community, that's something perhaps that PCC could consider in curriculum development or advocacy, targeting our community, targeting the provider healthcare community. I don't know, that just really rung true for me, Mike, in your comments around those issues.
Well, I think there's a lot of places that are doing it, and it's beginning to be taught to some degree in professional education programs as well. I think there's a recognition of how important it is, and it's. I mean, there are dozens and dozens of different cultural groups, and they're not necessarily all based on race or skin color. Or they can be based on many different attributes. And so fostering cultural proficiency or cultural competence should have even if you do it around a specific group such as Aboriginal people, should have an effect across the system for all kinds of other groups.
Sure, it can be on teen moms, pregnant moms. There's so many. You're right. Populations that we need to be thinking about.
We did have a question come in from Heather up in Inuvik, and she's asking for you, Dr. Wittenberg, is the Baby Love curriculum available for other programs to use?
Excuse me. It is available. We're open to going and training people in how to do it. We're interested in doing that.
Nice.
So they should just email me if they want to get involved in that.
All right.
Yeah, we're in the process of constructing our website, and shortly that will be up and available to people for more information.
Jean, what's the amount of training that's required for local people to deliver that program?
It takes 3 to 4 days of in-class training. I've just come back from Parry Sound doing it with a group of First Nations there. So about 10 people at a time, 2 leaders for each group. And then they go ahead and they begin collecting after this 3 to 4 days of training. They collect people for their groups, and then they speak to me on the phone once a week after each group for supervision through the course of 2 groups. And that's the training. And then beyond that, we provide ongoing education and support.
So we're getting to the very end of the sort of, this is the 11th hour of the 11th day of the 11th month of the sort of thing. And I just wanted to make a couple of comments about the fact that we've left out vast groups of people here in this discussion that we've had in these 3 excellent webinars. I'm very impressed with the quality of the presentations, and I'm not talking about mine, I'm talking about all the others. We have left out the whole issue of refugees, and we know just how poorly our federal government responded to that group by denying them some of the basic health care privileges that they'd had in the past. And so there are obviously important social policies that need to be in place to make sure that nobody is left behind. And the immigrant populations and each and every one of us has a different view of our own health and the health of the community, and that needs to be taken into account. So both individual, community, societal rights, and then the issue of the parts of healthcare where it's individual rights versus public health, which is the common good, and where those come to potentially clash. I think these are issues that we could very well discuss in future webinars.
Absolutely.
Mm-hmm. We did have a couple more questions come in, requests for Dr. Wittenberg's contact information. Dr. Wittenberg, is it the infant psychiatry program contact information that's on Sick Kids would be the best place to send people, or to you directly?
I would suggest that they just email me.
Okay.
So
do you want to put up your email? You had it on one of your slides.
Yeah, we'll put up your screen here, Dr. Wittenberg, and just so that people can have that. So that.
Okay.
There you go.
John, it looks like you're going to be busy.
I like being busy, so that's good.
Good.
Yeah, so it's john.wittenberg@sickkids.ca is what he's got up on the screen there.
Yep.
All right, well, that's all we had for questions. And I'm not sure if that was your final closing comments, Dr. Danneman, or if there's any...
Well, thank you to CAFC for hosting the webinar. Thank you to everybody from PCC who supported this. And most importantly, thank you to everybody who so willingly said yes when I asked them to participate in it. It was not a difficult process of getting people's participation. I guess I may have had a firm hand on their shoulder, but they were quite willing, and I really appreciate it, and we can't leave it there because there's much still to be done. So thank you all, and be well.
Thank you, Dennis.
And Dennis, if I can just add to that, I would like to thank you and PCC. First of all, Dennis, to you for your leadership and stewardship in bringing together the last 3 webinars as part of this series. There is lots more to do, and we're very committed to continuing our partnership with PCC to ensure that we keep this dialogue moving. There's tremendous work to be done, and I too just wanted to recognize the tremendous work and leadership of our speakers today.
Thank you all.
Well, I don't think there's anyone left for me to thank, since everyone has been thanked, and I couldn't agree more that it's been a great job throughout the series. So thanks to everyone for joining us. And we, as I always mention at the end, we do these webinars every Wednesday at 11 a.m. Eastern Time. And any parts that you might have missed, or if you have any colleagues that you'd like to share this information with, you can always go to our website and check out the CAFC Presents page, which will inform you of any upcoming webinars that we have on the agenda, and you can also direct them to the CAFC Knowledge Exchange Network at ken.cafc.org, and they can always find any of the recordings and other information related to webinars, as well as other information from throughout the child and youth healthcare community in Canada. So thanks everyone for coming, and we'll hopefully see you on the next one. Bye everyone.
Bye.